the way?
Yep. Just don't do that.
Just don't do. Yeah, I did. Hi, kia ora koutou katoa, ko Louise Takuangawa. I reside here in Aotearoa, and I am the adolescent and young adult cancer nurse specialist for the top half of the South Island. And I've been asked to come and speak on the ensuring equitable care for adolescents and young adults with cancer. A lot of the information and stuff that I'm sharing it's not mine, it's the whole Aotearoa Cancer Network and the awesome people who do the same role as me around New Zealand. I also decided to do that typical young person thing of, wow, well, I'm not young, but I work with lots of young people, and they're like, Canva's the best thing to use for presentations now, which is what I then did, which got us into this situation of not being able to use it properly. So anyway, hopefully this will work. Yes. So I guess what I'm going to touch on is first why they created this role. Like, why did they decide they needed senior nursing roles, and actually not just senior nursing roles, but a senior role that focused on this group of young people? Why adolescents and young adults with cancer important, and what inequities led to that, the development of these roles. I can't do a presentation without giving a little bit of education on adolescent development. I just can't, because it's just like so important. We're going to talk about the Aotearoa Cancer Services, the role. We can show some stats that impact not just the role, but the role are a really big part of the service. But, focusing on the needs of Aotearoa and what we can show, what the stats can show, the impact that that's had, but also where we find ourselves now and what's happening, what our fears are for the future, I guess. So that's a bit about what my talk is going to do. So adolescent development, I always like people to just take a second and close their eyes. If you can close your eyes and just remember what it was like to be a teenager and a young adult, and think about how important it was the way that you looked. Think about how, even now, and I don't know if I'm weird or if this is just how I think everybody thinks about these things, but if I think back to the relationships or the parties or the amazing nights out that I had when I was young, the emotions that are attached to them are so much more vibrant than the things, even the really significant things that have happened as I got older. So even like my wedding, like amazing. Obviously, the birth of my children, amazing. But the emotional vibrancy of the memories don't match what was happening when I was a teenager and a young adult. And that's not because that was more important. Totally wasn't. But it's just the way that your brain works at that time in your life and during adolescent development. So if we think about basic adolescent development, there's key things that young people are going through normally without a cancer diagnosis. They're figuring out who they are as a person. They're figuring out their identity, their ego, their morals, their values. They're supposed to be pulling away from that family network, from their parents, and developing independence, figuring out their vocational goals, sexual identity, like, what does it mean to be in a relationship? Who are they attracted to? Who's important to them? All of that stuff is really important milestones and experiences that they're supposed to be going through to become these fully functioning adults, like all of us in this room. So it's a really, really important time in their life, and a really tough time in their life anyway, without being diagnosed with cancer. And then if you think about, and I think if you take away any sort of adolescent development education from this, it's about the cognitive brain development and what's happening in their brain at the time and during this time of adolescence. So they don't think, like, if you have a young person with a cancer diagnosis sitting in front of you, their brain is not functioning the way that yours is, or the majority of the rest of your cancer patients who are older and have fully developed brains. So their prefrontal cortex is pretty much not finished developing until mid-20s, if not in males, late 20s. And so this is all that sort of like reasoning, ability to think about the ramifications of their decisions. Like if we're asking them to, like, don't do that and do this and do that because it's what you need to do to be successful in your treatment to be cured. And they're like, can't really do that. My brain doesn't do that. And if we think, so there's that part of the brain is still developing. And then there's another part of your brain, I can never say the word, the amygdala, that is like on fire, like it's absolutely firing. And that's your emotional center. So their highs are really, really high and their lows are really, really low. So I think that that's really important to remember when you see a young person, in the hospital who's going through a cancer journey or any sort of hospital journey, that, the way that they're going to be experiencing this is a lot higher and a lot lower than an adult. So that's my little spiel about adolescent development, just so that we can sort of not moving. Down. Oh, God. Yeah, we'll do the math. Okay. So adolescent development and cancer, they've got a bi-directional relationship. So I think when I first sort of came into this role, and I've been in it about 12 years, it was very much the effect, I guess people knew about the effect of adolescent development on cancer. So there were things like they're not compliant. They're not good candidates for clinical trials because they're not going to be compliant. They're not going to show up for their appointments. Everything like that. There was like, well, because of what their age and where they're at developmentally, it's going to affect their cancer journey. But it happens the other way around as well. And that's not me saying that that's true. I don't agree with any of that really, but that was the thoughts. But it's also the other way around. And I think this is a key thing about these roles in this service as well, is that if you've got all those really important things that need to happen for you to be a healthy, functioning adult at the end of it, and then you whack them with a cancer diagnosis and cancer treatment, that's going to have a huge impact on their adolescent development. So their ability to develop a good positive body identity, their sexual identity, their independence from their parents, all of those things are going to be massively impacted by their diagnosis and their treatment. So that's, pretty understandable as to why, AYA needs some specific focus. The research showed that young people who had treatment for cancer in adolescence and young adulthood had less, they didn't achieve as well in education and in their jobs or in a vocational. They had lower quality of life. They were less likely to be in a partnership or have a family. Their engagement with health services in the future was not as good. Higher incidence of mental health. Financially, like it was a massive hit financially for them because they just didn't have that structure. They'd lost all that ability to be able to learn how to earn and, do the education that they needed to have a well-earning job. They didn't have that insurance. Like sometimes I feel like I'm complete doomsday conversation with a young person after they've sort of towards the end of their treatment, and I'm like, oh, they're like, oh, I'm going to go traveling, and I'm like, travel insurance. And they're like, oh, I'm going to buy a house. And I'm like, oh, life insurance. Like, like the ability to get insurances, which is, all that is affected because they've had a diagnosis at such a young age. Distress levels are really high, higher and higher sexual dysfunction. So I guess, what happened is that the New Zealand's cancer control strategy was released in 2003. In that, it said that in New Zealand, there's no consistent, equitable pattern of referral and management for adolescents. And they quoted the falling between the gaps. And it's very much about, you've got an adult cancer service that's very much driven and set up and functioning for adult patients. It's like, it works well. You would probably argue that it doesn't work for them, but it's designed to work for them. And so when I started in this role, a really simple example would be, you got mailed out your appointment. Like, young people like, that doesn't work, or you just mailed it out and just expected that they'd come. That doesn't work either. But then you've got this, pediatric oncology, pediatric cancer service, and, they are focused and determined to, cure cancer in young people. They've got nurses that are specifically educated to look after pediatric oncology patients and their whānau. They've got clinical trials that are absolutely designed and recruiting internationally for pediatric cancer patients. They are improving outcomes for teenagers, for children. And then you've got nobody looking at this young group of people. And if you just look at clinical trials, the adult clinical trials, they would be they'd have a lower age limit that didn't include my age limit, which is 12 to 24. And the pediatric trials would stop at 16. So there's no clinical trial eligibility for them. So they were really falling between the gaps. No one was focusing on them. So they weren't doing as well. So what came out from the action plan from that was the creation of the regional AOA cancer services. It aimed at improving cure rates, reducing psychosocial morbidity, accessing clinical trials, and pretty much advocacy for this young group. So they split the New Zealand up into regions. And I guess, there were services that were set up, within those regions, but the key parts of those services were the AOA cancer key worker role. The majority of them were sat within senior nursing role, but actually one of them sits within the social work department, and it's been a social work role. I'm pretty sure most of its time. The role was supposed to cover a geographical area, and there's different amounts of FTE to different areas. It was before my time, so I don't know how they figured that one out. And the first people that were into these roles were really about setting up this service, and then it's been built on since then. It's about psychosocial assessments, care coordination, really looking at trying to decrease the impact of cancer on that young person's adolescent development, advocacy, and really just trying to really focus on these young people within the existing cancer services. The funding, there was pretty much only the funding for the roles, and once again, I wasn't there at the inception of this, so I'm not 100%, but it seems like there was funding for the roles. There was a little bit of funding for a clinical lead in each of the areas, which has disappeared in most of the areas, somewhere into the abyss. And now we do have some funding for psychology in some of the areas as well. Think about the role to give you guys a bit of an idea for the 12 years that I've been doing it. It's a real balance. It's a balance between that patient care and that service development and strategic development. It's constantly a balance. The patient care is very much sort of we're doing heads assessments on young people to really figure out what's going on for them and where their need is. We're doing care coordination, doing developmentally appropriate education. So, I will find even, I've got a young person that's maybe lucky enough to be in pediatric oncology, and I'm like, yes, just because it's just got wraparound service, they're easy access to everything. It's not that I think that they're better. It's just that, if they're in adults, I'm like, I need a social worker and I need a psychologist, and how can I get that to happen? It doesn't just happen automatically. So if I've got a young person that's in pediatrics and they've had education about their cancer, I can still sit down there next to them. I'm like, can you tell me what your diagnosis is? And they might be able to. And I'll be like, can you tell me what your chemotherapy involves? And it's not that I doubt that discussion hasn't been happened. It just hasn't happened in a way that they've absorbed it and remembered it. So it's about trying to give it and deliver it in a way that they understand. Lots of advocacy. Fertility preservation is a huge thing for young people that we've done a heaps amount of work in, and advocating and making sure these early referrals go out and they get access to it and they get funding, and it's not just gone, it's too hard. It's in too hard basket, or we need to get onto treatment straight away, we can't wait. Actually, you need to have those conversations with them. That's their choice. And lots of liaising and stuff, I think. And then the other thing is you're developing a service, you're developing resources for many years, and even many years before I did it. There's a lot of trying to develop resources without any funding, which most of you will know is really, really hard. You've go, we need it, we've developed it, it's great. How do we actually produce something that can be used when we don't have any money? So it was about, trying to remember the date that we got some funding through, it's back here, that was announced in, find my dates. Anyway, doesn't matter. So we got some funding to create the Aotearoa Cancer Network, which is where we then actually had some access to some money to create some of the amazing resources that we have. I've just put a few of them up there. But, you know, we also did, the network did a patient experience survey to really guide what the young people wanted and what they saw that gaps were. So there's been quite, like, we've developed a big survivorship resource, which is for, you know, young people when they finish treatment, because they were like, that's the hardest part, is what now? We really need support there. And we did, you know, we also did lots of research. We've done studentships, everything to try and figure out what we need to do. So it becomes a bit of a balance, and it's always a bit of a balance. So these roles have been running for quite a while now, about, I'm not going to get this right, and if one of my colleagues is watching me, they will criticize it, but it's about 20, no, it's not, it's less than 20 years, about 18 years, something like that, 17 years maybe. And so they did incidence and survival data for Aotearoa with cancer. And so the first cohort was between 2000 and 2009, and the second was between 2000 up to 2017, and looked at the data. And what we found is, you know, cancer rates did improve, and even we saw improvements within ethnicity as well. We do have ethnic survival gap, absolutely, for Māori and Pacific Islanders. They do not do as well as non-Māori, and but that is something that has shown some improvement. Our gap between, if you compare us to Australia, has also improved, but that gap is still there. And also teenagers versus young adults. So that real 15 to 19 year age group don't do as well. And we think that is related a bit to the incidence of bone sarcomas, but that's a real group that showed that when it's not doing as well, they're not doing as well. And then we went on to find that actually it also shows the other inequities, which is locality. And this has been discussed by the other speakers today. But interestingly, our data was able to show that those who were sort of in that 50 to 99 kilometres away from their tertiary hospital were the ones that did the worst. Anyone want to guess why that is? MCA. Far enough to it be a decent trip, but they can't access any funding assistance for it. And then also those that were, you know, living in your main urban areas did the best. Māori and Pacific Islanders, and also bone tumours, which I've already mentioned, where our inequities lie. And also deprivation. So those with the highest deprivation had the poorest survival rates. So the highest survival rates for Aotearoa are found in those that live within 20 kilometres of a tertiary hospital, they live in an urban area, and they have low deprivation. So we were pretty clear about where, you know, where we needed to focus. And I guess this is where we get to the so what now, which is where I find myself sitting. Like, and you probably, most of you feel pretty similar, is that it's in the media all the time. The health system is, well, they talk about crisis and they talk about strain, and we can all feel it. And I think for me, this role has been under-resourced since its inception. I think when it was handed over to me 12 years ago, the person said, you need more FTE, get more FTE, which I haven't been able to do. And a lot of the service, apart from, you know, my role, is that we're working on donated time. So I've created a team in my area that has, you know, a pediatric oncologist, a hematologist, an oncologist, a psychologist, a radiation technician, a social, you know, we've got this team none of them are actually funded to do anything with AYA. They're just interested and they're donating their time, and that has worked up until now, or probably not so much now, probably a couple of years ago, where everybody's home base, if it's pediatric oncology, hematology, is under so much pressure and so much strain, they don't have the time to put into AYA like they used to. So we're finding that a lot of the stuff that we gained for young people is really starting to slip away. I used to be able to get people's appointments changed really easily. So it worked with not only that they could get there, that I could be there with them because I'm not funded full time. So can it be on a Monday or a Tuesday or Thursday? That never used to be a problem. Not easy now. So those sorts of things we're feeling like we're losing. Also, we're seeing of young people who are, they're being diagnosed and they've already got pre-existing mental health concerns. A lot more who have, are on treatment for anxiety, depression. We're seeing an increase in, multi-drug recreational use, and real increase in psychosocial supports and numbers. Like my numbers when I started in this role were sort of 20 to 25 newly diagnosed patients a year, and now I'm up at 40. So and there's been no funding increase. So we were like, what do we do? I was feeling immense guilt. We get together as a key worker group once every year, usually face to face. So far, I'm nervous about that too. I was turning up going, I don't know what to do. I can't do the HEADS assessments. I'm not able to do these things with my patients because I don't have enough time. And so we really had to look at what do we do with an increase in need, but not enough resourcing. So we started to look at a bit of an eligibility and a tiered framework of care. How do we prioritise and care and provide the most appropriate care to the people with the most need? And what do we do about the ones that we can't work with? It went on to our AYA Key Worker work plan. These are some of the versions that we sort of went through. This is only a few of the people, me with my sticky notes, sort of figuring out what we were going to do. So we've ended up with an eligibility form. Two tools. First is the eligibility form, which pretty much just identifies who's eligible for the AOA Cancer Service and who's not, and also who's eligible for sort of level 1 care. So that might be someone, for example, that has a melanoma, that it's just been cut out. They just need surveillance. There's no further treatment required. And then we've developed tools to be able to send out to them. They are key worker, and it doesn't have to be the key worker in their region, which is another key thing, because some of us have different, our patient numbers are different, and we have, more flexibility or less flexibility. So the key worker will contact them, introduce them, let them know how to find tell them about NGOs, send out this form, direct them to the AOA Cancer Network website that has lots of resources on it, and sort of just check in. And that's sort of what a level 1 person would be entitled to. And then we have a tiered framework for those who are eligible for level 2, 3 or 4 key worker support. Level 2's sort of like an oversight. Level 2 and level 3 is coordination, and level 4 is key worker management. So right at the top, it prioritises those who are Māori, Pacifica, living rurally, or have a high suspicion of risk factors that might impact on their engagement with health services. So those people, if people identify as a priority, they'll be contacted by a key worker within 7 days, goes down the other side. And we've got 21 days for people who we don't identify as one of those priority categories. Then we've got we screen for sort of like a treatment factors, and these are things that we should be able to know without really contacting the person, hopefully. We might get from some of the notes that we can see. So if it's a guarded or poor prognosis, if the treatment is likely to have a long-term impact on that person's health. So, for example, they're going to have a bone marrow transplant, they might have an amputation, expected long-term hospitalisation, comorbidities, if they're going to be undergoing treatment away from their normal residence. So I would put in this points university students, like, you know, people who are maybe here for university, their families all in somewhere else in the country, they're flatting or they're in halls of residence, you know, those sorts of things. And if there was multiple specialties involved. So I always think about people who maybe are going to be, if they're in pediatric oncology and they're heading to radiation, or if they're going to be going up to Auckland for a transplant, like, then I'll get involved for that because of that reason. And then there's a screen for psychosocial factors that then, which is the next section, that looks at levels of distress, social supports, connectedness, health literacy, lots of those things. And it sort of tells us the level of support that that young person should receive. So ultimately, I guess, you know, it was identifying that, you know, AOA didn't have equitable service within cancer care services that came to, you know, led to the creation of these roles. And then as these roles and services have developed, we've been able to knuckle it down a bit more to what the inequities are within this population, and are now trying to focus on them with the limited resources that we have. These tools are really early days, so we are just sort of using them now. So I can't really feedback on how it's going, apart from it's just really good to have something that we can start to use and hopefully will help us to really figure out who we need to be directing our time to. References. Thank you so much.
Does anybody have any questions?